Well, let me say that we're very privileged as the Rogosin Institute, together with the New York Presbyterian healthcare system, to welcome all of you this morning and about 30 or 40 others who should be showing up shortly. The symposia, this is the second, as Wayne said. These symposia, we hope, will be an ongoing series that opens discussion on many of the key areas in nephrology for today and tomorrow. And we're excited about those prospects. And we are recording the lectures as we did last year. These will be available on our website and YouTube and eventually iTunes University. But we're anxious to see these go beyond being just symposia, which are important enough in themselves, but going on to be things that raise questions that need discussion, that raise policy issues, scientific questions, and so forth. Anyway, we're delighted to have all of you here today. And by way of just introducing the day, and I think we have a wonderful group of speakers today. I know we have a wonderful group. And we're going to cover a range of topics from physician needs, nursing's role, other health professionals who work as part of the nephrology healthcare team. We're going to raise questions about how that team should be constructed or put together in the future. And we're going to end with a talk on particularly two talks really on community-based efforts, and I think increasingly that's going to be an important part of what we do. Well, you have the program. I won't dwell on that. And I don't know that I've got this exactly right in terms of, and I'm sure it depends on where you are, what the team is, and so forth. Physicians, nurses, nurse practitioners, advanced practice nurses, LPNs, patient care techs, phlebotomists, dietitians, social workers, and you could add your own list. So that's what our workforce is today. And nephrology, or nephrologists and nurses, the team, see people in different settings today, from the office to renal and CKD, chronic kidney disease clinics, to the dialysis unit, the hospital. And with health reform, with some of the things that are changing, and with, if you look at, from the US RDS, some of the prevalence counts by primary diagnosis, for example, you'll see that diabetes and hypertension, for example, are two of the leading causes. And obesity, of course, goes along with that. So it raises questions if we're going to be preventing disease, if we're going to do a better job of taking care of patients, where and how are we going to do that? And I think what this does, and would be interested in our speakers this morning telling us what they think, the community is a missing piece, and it's a missing piece in a lot of medicine. Chronic disease management, I think that's an area that we're going to be spending much more time in. For example, how about the awareness of kidney disease? There isn't that much awareness. We need to improve that. But a lot of the interactions, a lot of the things that will change kidney disease and the future of kidney disease are things that can take place in the community. And I think the new nephrology workforce, and again, we will hear much more from real experts on this, the team is going to consist of the people we've already talked about. You can add some others to that. But I think very importantly, community residents and leaders in communities are going to have to be our allies to really change the face of disease. I'm not sure that we can count on being behind our 4 clinic walls and being as successful as we need to be. So whether it's office, the clinic, the dialysis unit, the hospital, an integration with the community seems to me to be very important for the future of the workforce. And how we do that, of course, is a big question, because what what we want to provide is a continuum of integrated whole person care. And we're going to have to, I think, change a lot of the things that we do to make that possible. Part of the problem is that an individual with hypertension or diabetes in the community is not a diabetic, is not a chronic kidney disease. That's a person who has a whole range of life problems that need to be addressed, and we need to be much more involved in that. And again, I just throw this up for consideration by everyone today to think about it. I think that the physician's role is going to continue, obviously, to be an important one in overall disease management and some of the research areas in the laboratory or in the clinic. The nurse is a crucial piece in bridging what happens in private offices, the clinics, whatever, to bridging that to what happens in the community, to what happens with families, how we change lifestyles to prevent some of the disease problems we see. Social workers, dietitians play an important role. Obviously, the patient care technicians, LPNs, and others function in the dialysis unit and the hospital unit. But again, thinking about the community resident, how do we integrate them into this workforce? I saw a statistic 2 days ago that there are 15 million caregivers for individuals with Alzheimer's disease in the United States. Now, that's a workforce that we haven't even thought of tapping, not particularly to Alzheimer's disease per se, but clearly we are not using the power that's in our communities to address some of the disease issues. And it seems to me that renal disease, or nephrology in particular, needs to take a lead in changing the models in which we address the problems not only of kidney disease, but chronic disease more generally. A colleague of mine, Diane Meyer, who's in palliative care at Mount Sinai Hospital, I saw a lecture she's about to give after she spent a year in Washington as a senior congressional fellow. And the title of the talk was, "Get a Seat at the Table or Beyond the Menu." All right, I think there's a very important point there for nephrology. If we are going to be out there and changing things, we need that seat at the table. We don't want to be on the menu. And we need to take that activist role. So for today, some questions that I thought of, and you may have others that are much better. How should we think about the nephrology workforce of today and tomorrow, especially in the light of health reform? Do we need new models? What should they be? How can we get beyond the usual obstacles, which have to do with everybody has to make a living, for example, turf battles, whatever you want to call them. Physicians, what should their role be? What about nurses? What about the other team members? Is everybody being used to the maximum? And how can individuals and communities be mobilized to be part of the nephrology workforce in the fight against kidney disease, in the better management of chronic kidney disease? So those are issues that I think we'll be addressing during the course of the morning. And without further ado, to turn it over to true experts, I'd like to call on Professor Joseph Bonventry, who is a professor at Harvard Medical School, chief of the renal division there at the Brigham and Women's Hospital. He is currently president of the American Society of Nephrology. He is many other distinguishing distinguishing characteristics in acute kidney, study of kidney injury and repair, stem cell biology, bioengineering. His career is a tremendous one, and I think we're very privileged to have him here this morning to give us a picture of just where things stand in nephrology today and how ASN and he in particular sees it. Just by way of two things I do need to say by way of announcements. We will hold questions till the end. You've been given index cards. Please write your questions on those, and at the end of the speakers, we'll have a panel session to address those. And for the nurses, there are 2.5 credit hours available through ANA, the American Nephrology Nurses Association, for attending this symposium. You need to have signed in, complete the evaluation form that you should have gotten when you checked in, and before you leave, return that so that you get a certificate from the volunteers at the registration desk. And next year, we will have medical education credits as well in collaboration with the New York Nephrology Society. With no further ado, Dr. Bonventry.